He is a medical. Dr. Anant Bhan is a medical trained doctor, and he has done his master's in bioethics from the University of Toronto, Canada. Presently, he is an adjunct professor at Yenepoya University in Mangalore and is a guest faculty in several national and international educational institutes also. He is a reviewer in various scientific journals and various scientific committees as well. Dr. Anant Bhan also is a principal investigator in several grants at Sangat Bhopal, which is primarily a research-focused NGO. Interestingly, Dr. Bhan is also leads a bioethics training initiative called Drishti. Besides all these, Dr. Bhan is also a member of the WHO COVID-19 Ethics and Governance Working Group and is a member of the steering committee in the global research, global bioethics forum on bioethics and in research. He is also in the editorial board of the Asian Bioethics Review and is also a member of the
डॉक्टर बारी आप म्यूट हो गए हो.
Sorry for that. Before I request Dr. Anant Bhan to carry this webinar forward, I would request all the attendants to keep their mics in mute and keep all the questions for the question answer session, which will follow the talk. Dr. Anant Bhan, please, you can start with the presentation.
Thank you so much, Dr. Bari, for that kind introduction. And it's a pleasure to be here today in the AHA webinar. I would like to certainly thank the organizing committee, Mahesh, who I know now for several years, and who is also certainly very interested in ethics. So I think the idea was to cover some ground around issues which might relate to the practice of medicine and hospital administration, but also specifically around the role of ethics in those scenarios. And towards that, what I will try to do is I will try to cover some ground, raising some issues, and hopefully that will lead to some open discussion. I just wanted to make sure that if it can be confirmed that my slides are visible and that I'm audible clearly. Can someone just let me know?
Yes, sir.
Yeah, all right, great. Okay. So I think over the last few days, you might have seen that there's been this series of articles in the Times of India. Dr. Devi Shetty, who is a cardiac surgeon, but also is the owner of a chain of hospitals, has sort of raised this issue that there is a need to do more to identify individuals who might be at risk of heart disease earlier. And he advocated for the use of technologies such as CT angiography to do that, right? And more from a screening purpose. Now, most of us know that these are largely diagnostic technologies, not so much used for screening. And when it comes from an influential figure like him, it could influence practice in many ways. Very quickly, we saw a response come in from two cardiologists, both trained at AIIMS, one of whom was also the ex-DG of the Indian Council of Medical Research, saying that this kind of an approach is not based in evidence and we should not be encouraging it. We should not be pushing technologies such as CT angiography for routine use. These should be only used for diagnostic purposes, and it's not good for any doctor to be actually advocating for its usage. So And just yesterday, another article saying that we should not be going in for advice from celeb doctors. We should be looking at evidence in a more unbiased manner and then taking a decision. So this tells us something interesting. It tells us that within the field of medicine, of course, there are varying perspectives around how to handle important health issues. In this case, the rising burden of non-communicable diseases, cardiovascular diseases in the country. But also in today's times, what role does evidence play? What role does individual opinion play? And what is the role of social media and conventional media, and how all of those could sort of end up confusing a layperson who might be the patient, who might follow a particular perspective, not knowing whether that is evidence-based or not. So something interesting for us to reflect on. Now, a few years ago, if many of you would remember that there was this controversy around faulty implants, largely related to J&J, but also reported for some other companies. And in this case, these faulty implants were not just in India, they were actually in some other countries as well. In those countries, compensation had been paid out, and replacement surgeries, replacement implants had to be put in by the company for those patients who were identified as having faulty implants put into them surgically. In India, it sort of went down a black hole. There was a lot of patients probably with issues related to some implants, but compensation has not really played out in the same way as it's played out in other countries. And they have been left sort of to their own devices to try to figure out how to handle these kinds of complications. And what is the role of a hospital ecosystem if these kinds of things happen, right? Because of course, hospitals is where these surgeries happen, typically tertiary hospitals, maybe in some case, secondary hospitals as well. So what does the hospital ecosystem, the treating clinicians, and the governance mechanism owe to these kinds of patients? So this is where I think it may be interesting to think about what could be the kind of ethical issues that we need to talk about. Now, very simply, ethics, as many of you might already know, relates to this kind of a reflection on what might be right versus wrong, right? It is derived from the Greek word ethos, or behavior. And essentially what we are doing whenever we're doing ethical reflection is trying to reflect on a certain practice, behavior, and then saying, is this right? Is this wrong? And then trying to figure out a systematic analysis and resolution of those kinds of two areas of thought that we might have. And specifically when we apply the field of ethics into healthcare, into biology, life sciences, that's what we call bioethics, right? And typically what bioethics will help us do is to reflect on moral problems that we might be facing in healthcare or research, and then help us decipher what we should be doing in a particular situation, why we should be doing it, and how we should be doing it, right? So it's almost like a framework or a lens which we can apply for us to be able to have more clarity, especially when we are faced with a moral dilemma. Now, as Dr. Bari said, the field of ethics and its interplay with medicine is probably as old as the field of medicine. Many of you would know that there was a lot of description around
unethical. Dr. Bhan, could I just interrupt you for a minute?
Sure.
I'm Jal Jagtar. One, your slides are not on the slide show mode. Secondly, okay, they are not moving. So
where exactly are the slides right now? Which
right
slide?
Now we are just seeing the New England Journal of Medicine wala slide.
All right, okay.
So if you can put it on the slideshow, because there are comments also in the chat box.
Right. So I did put it on slideshow. Can you confirm if it's moving? Otherwise, I might have to try resharing.
No, because
Anand, you reshare it. Anand, you reshare with the present in this, what they say, the
yeah, what I'll do is I'll maybe just share my screen and then let's see if that helps. Are you able to see the slides now moving?
We can't see the slides.
Not yet. Not yet.
Okay. Let me try that one more time. Okay, now?
Yes, now it's visible.
Yeah. And
that's
they are,
okay.
and they are moving.
Yeah, they are moving now.
All right, great. All right. Thanks for alerting me. That's very kind of
Yeah.
you.
Now you are on the slide of New England Journal of Medicine.
Yes, yes. So
Yeah.
what I was speaking to was the fact that, um, as you know, there were a lot of controversies around the conduct of unethical research during World War II, especially by the German army, the Japanese army, and that was led to a whole set of trials, the Nuremberg trials, which were conducted for the German doctors who were working for the army, who had conducted these research on prisoners of war. But there were also many other descriptions. So one of the most influential articles in the field of bioethics was written by a physician called Henry Beecher, and this was an article in 1966 in the New England Journal of Medicine. And what Dr. Beecher did was he cataloged a whole series of experiments which had been carried out, especially in hospital settings. And there were a number of them. You know, he listed out almost I tend to think around 12, 13 articles where he spoke about these kind of studies where there were concerns around ethical issues. And he said that the way we are right now handling ethics needs to have more attention paid to it. And that actually led to a lot of reflection within the field of medicine. And that's where, in many ways, in the US especially, there was a report which came out, which was the Belmont report, which was influenced by the Beecher article, but also a lot of follow-up discussions, which talked about multiple areas. But what it also did was come up with a series of principles. And these principles focused on largely 4 areas. These are known as the 4 principles, or the Georgetown mantra. And these relate to autonomy. So the focus is on medical personnel honoring the right of individuals to make their own decisions, on beneficence, so doing good, on non-maleficence, which is trying to do no harm. As we all know, within the field of medicine, doing no harm is an important facet of medicine. And then justice, which is to ensure that whatever we are doing is done with a focus on fairness and equity, and to apply also objective standards of care to similar cases, so that you're not discriminating against anyone, you're not providing preferential care to a particular set of individuals and not to the other persons. Now, how this was applied then in research, of course, is what we typically use. For example, autonomy is applied in the way we apply or obtain informed consent, in the way we focus on confidentiality, rights to biological material. So especially in hospital settings. Just give me 1 second, I'll try and get this. 1 second. My apologies. Sorry, I had a call coming from family. Let me try sharing again. Give me 1 second. All right. So what we were talking about hence was the kind of principles which came through and how these were applied. So you have consent, you have confidentiality, you have rights to biological material, usage of samples. Then looking at beneficence and non-maleficence, these relate more to how you deal with risks or harms, how you deal with conflicts of interest issues. In justice, we look at participant selection. How do you protect vulnerable participants in research? How do you address issues around stigma and discrimination? Because as we know, that is certainly a concern, both from medical practitioners in some cases, but also largely from communities, especially, let's say, in infectious diseases like leprosy, tuberculosis, Mental health, where I do a lot of work, stigma discrimination is a major issue. Coercion, where people might be forced to take certain decisions or to participate in certain research studies. Whether everyone has an equitable chance at being able to have opportunities to participate in research. Are certain people more exploited or more likely to be participating in research? Are certain communities over-researched? And what kind of issues do we talk about in terms of once the studies are over, do those research participants have access to the interventions which were being studied? That is typically what we talk to when we talk about post-trial benefits. Now, of course, in India, we've also had a lot of development of guidance around this. The latest version of the Indian Council of Medical Research National Ethics Guidelines came out in 2017, and they also talk about certain principles which would largely be relevant to research, but I think also could be extended in some cases, at least, to the practice of hospital administration. So only doing, for example, research which is essential, which is based on a social value or a scientific value, doing this in a voluntary way, right? So not forcing anyone into participating, not forcing anyone against their will to do anything which they don't want to do, not exploiting anyone, doing your research in a socially responsible manner, ensuring that privacy and confidentiality is maintained. So typically these words are used together. The way to look at it is privacy is sort of the kind of a boundary that we draw within a professional relationship, let's say a doctor-patient relationship. Within that boundary, whatever is shared by, let's say, by the patient to the doctor, it is supposed to be kept within that boundary, right? So if I have that comfort level and I recognize that boundary, I might share personal information about myself, which I'm not going to be sharing with other individuals. Once that information is communicated to the doctor or the healthcare provider, what they do with that is confidentiality, right? Securing that information, keeping it secure, not sharing it with other individuals outside the healthcare space is what is confidentiality. Now, while they do that, of course, they also need to ensure that any risks which the patient might be undergoing or the participant might be undergoing is minimized. You have to ensure that whoever is doing the research, whoever is doing the clinical procedure is professionally competent. For example, they might be a great surgeon, but they might not be trained to do qualitative research. So suddenly, if they want to do a quality of life study on their patients, have they ever done qualitative research? Have they gotten training in that discipline? Would be the kind of things which would be asked of. And this is what ethics committee does, for example, in looking at a proposal. How do you maximize the benefits for your patients? How do you make sure that everything is carried out with solid backup, right? And typically that requires institutional arrangements to be there. How do you ensure that there is transparency and accountability? And I think this is also important because, as you know, all of you deal with this on a daily basis. There is a certain trust deficit right now in the practice of medicine and healthcare. And this, of course, sometimes has negative consequences, such as violence on healthcare providers, violence on facilities. Of course, no form of violence is acceptable in any way, but is there a role for also building more mechanisms around transparency and accountability in the health system is something to think about. Totality of responsibility basically means that anyone who is in a leadership position, a principal investigator of a study, the head of a department, the director of the institution, the managing director or the lead hospital administrator, they have to take responsibility for everything which happens within the realm of what they are leading. And they cannot say that someone in my accounts department messed up, or someone in the medical records department messed up and they did not ensure that information was kept confidentially. You have to build in those systems in your institutions to ensure that people respect those boundaries, respect the ethical requirements which are there. And environmental protection basically talks about the fact that in today's world, we also need to be eco-conscious and not damage the environment and be careful with the way we deal with biomedical waste, etc. Now, of course, this is within the realm of a situation where we know that the health system has progressed a lot in India. We have a mix, the public sector, the private sector, but still there are a lot of gaps, right? And the kind of gaps that we know are largely also in parts of India which are more marginalized, away from the mainstream, rural, tribal, where you might not still have healthcare being accessible And so we keep hearing, of course, stories like the one depicted on the slide. And this was also something that we saw during the pandemic, right? That on the face of it, we had a hospital network, at least in urban India, which was supposed to be competent, it was supposed to be resourced, but there was almost this kind of a weak base, right, which got exposed during the pandemic, especially during the second wave. And it tells us something about the need for more resilient health systems, more investment in our health system, more investment of in the area of public health, which could have helped perhaps avoid. And since then, one would say that certainly there's been much more investment, more labs, for example, set up, which can do quicker genomic analysis of strain variants, more better surveillance mechanisms, more oxygen availability, etc. And I'm sure that's true of many of your hospitals as well. But at that point of time, I think we stood exposed in many ways. And this, of course, is in an environment where also, especially in rural India, there is still an acute shortage, especially of specialist doctors. So if you look at community health centers, that shortage of specialist doctors is almost in the range of 80%. And it's the most acute in the northern and eastern part of the country. And of course, that is a cause for worry, because that would also mean that a lot of individuals are not getting care that they need, especially in the public sector, early enough. And these individuals might not be going to tertiary centers till they actually reach a very complicated phase of their illness. And that at that point of time, it is usually more difficult, complex to treat that kind of a disease. Now, specifically in hospital administration, I think many of you, I mean, I'm not an expert in this domain, all of you are, but my hunch would be that, of course, some of the challenges that you would be dealing with is that there are a lot of new advances which come through, the latest new MRI machine, a new way of doing things, robotic surgery, etc. But these are also relatively costly, right? So do you invest in those, or do you look at quality of care as a metric? How do you balance those two and ensure that at the end of the day, the patients who are coming to your institution get high quality care? And where required, you of course use technology to enable that, but it is not always that there is a focus largely on getting the latest technologies, which might be costly, but are those the right fit for your institution, for your patient base, is something to think about. Two, our health system still is very hierarchical. As all of you know, there is a lot of deference to authority, which would mean that patients might say, whatever you decide, doctor, is what I want to do, what I'm willing to do. In some cases, of course, they come equipped with information or misinformation based on reading up in Google, but that is still relatively a minority. But then how do you exercise practice where autonomy of your patients is encouraged, where they are asked to take decisions, perhaps in a collaborative manner, but that is still a struggle in our setting. And also, of course, we have to recognize that in our society, it's more communitarian as well. Individuals don't take decisions on their own. They involve family members, friends, etc. How do you ensure that you maximize benefit for your patients and reduce the risk? And then how do you maintain professional conduct within the institution? And I think these are aspects which perhaps sometimes have not been discussed adequately. I was part of a group which was convened at St. John's almost a decade ago, which came out with a consensus document which deals specifically at an issue called boundary violation. Right? Typically now, as you know, a doctor-patient relationship is a fiduciary relationship. It's built on trust. It's a very much a professional relationship. But when there are boundary violations of various kinds, then that could raise uncomfortable questions, right? And one, we need to be aware of those. Two, we need to ensure that in our institutions, our practitioners are aware of that and that they are cognizant of those issues. So the Indian Psychiatric Society, in fact, has come out with guidelines for doctors specifically on sexual boundaries with respect to patients. And one of the things that was, of course, proposed in the initial Bangalore declaration was that this is something that the Medical Council of India, which was then in existence, should be taking into account. And now, interestingly, the National Medical Council, if you go to their website, has put up these guidelines. So in a way, recognizing that we need to talk about some of these issues as being important. Now, boundary violations are of various kinds. Some of those are clearly in the realm of not being acceptable, for example, sexual boundary violation. But there are many other practices which are culturally considered more acceptable. For example, your patient comes back with a box of sweets or a box of mangoes during summer. Is that okay? Taking gift from your patients, and most people would tend to think, of course, that's perfectly fine. They're coming with an expression of love and thanks. But where does that boundary lie, where that acceptable, non-acceptable might be there? So this might be something to think about. And this is where I think there's been some interesting writing around what kind of competencies in ethics specifically should be there in hospital management, right? In terms of the decisions that need to be taken. So do you have the tools and frameworks to enable you to take decisions which are driven by ethical thinking, which help you deal with it, with these situations as a team, because healthcare is a team based process and endeavor. How do you ensure that you are also looking at alternative options to help exercise choice for your team of practitioners, as well as perhaps for the patient and their families? How do you ensure that you do supported decision making for all of the relevant stakeholders in this environment? How do you ensure that there is respectful engagement, which helps in making decisions? How do you involve ethics expertise? For example, do you have an institutional ethics committee or a clinical ethics committee? Some hospitals do have this even in India. How do you focus on ensuring that the person is at the center of the care which is provided, right? And how do you also, and this is not just about the patient, it's also about your employees, it's also about the providers and how they are supported to deliver on high quality care. How do you ensure that there is no discrimination in the way the practices are going? How do you deal with conflicts? How do you take responsibility in terms of professional management? How do you ensure that there is dignity of work? If anyone has made a mistake, because, as you know, medical errors can happen all the time. In fact, they do happen. And in some cases, they could lead to more additional morbidity. In some cases, they could even lead to, unfortunately, mortality, right? Medical errors are also a cause for mortality, especially in the health space, and there is a lot of documented evidence towards it. But if a mistake happens, then how does the hospital deal with it? Do we pretend it didn't happen? Do we try to hide it? Do we deal with it in a manner where we are upfront about it and respectfully engage the patient party in explaining what happened? Of course, there is the liability part to it, which is a cause for concern. But there are also several incidents where I think a lot of patients and their families go down the liability pathway because they feel that they were not communicated to, they were not talked to, they were not told that something wrong had happened or something went amiss. And if that ownership had been taken, perhaps they would not have pursued a very adversarial pathway, which then goes into courts, then goes into a medical negligence pathway. So that is something for us to think about. I know it's not easy. It is certainly difficult, but from an ethics perspective, having the courage to admit mistakes and also talk about what we are doing to fix them is something which perhaps our institutions need to think about. And of course, then integrity around, how do you ensure that the whole institution is built on this precept of ensuring high quality care, transparency, decision-making, which is collaborative in nature, zero tolerance for abuse of power, etc. And then how do you also, again, put all of this into practice through training and development, regular updates, developing pathways so that individuals understand how to treat patients better and in a kind manner. How do you ensure equity and access? What does the organization need to do? How do you make your organization and institution socially responsible, right? So again, this article is available. I'm happy to send the reference, but this does reflect on multiple areas within the ethics realm which could be applied into hospital settings. Now, what happens typically then is some of this could get a little bit more complex, especially during health emergencies. And COVID was a good example, right? You had a health emergency, a pandemic, where things were much more difficult to handle, even for hospital managers, administrators, right? Because at that point of time, the benefit that we think of typically in healthcare, rather than focusing on the individual patient, becomes more public health oriented or society oriented. So you're not so much thinking about the well-being only of an individual patient, but also of society. So you try to do the most good for the most people. That would mean that, for example, you might be willing to suspend the liberty and rights of certain individuals. And we saw that happen: isolation, quarantine, if someone is suspected of infection; isolation if they have been confirmed to have COVID-19. And that is done with the idea that this will protect others who might potentially be at risk, right? So that is an example. Applying justice, which in this case would mean that if you have a shortage of beds, if you have a shortage of oxygen, and there are a lot of people outside your emergency department trying to access care, then how do you decide who gets paid? What kind of triage mechanisms do you build in? And are these clear? Are these concise? Are these available to everyone? A little bit of audio disturbance. Yeah, thank you. So are these clear to everyone, and or is there a way of being able to beat these, right, by someone who is politically connected, making a call, or someone who's known to someone making, or someone who can pay, being the one who accesses the priority and not the medical reason, but a non-medical reason? And how do you deal with those kinds of situations? How do you ensure that all of these kinds of guidance documents and institutional practices are implemented in a consistent manner, right? Which is what will lead to trust. An external set of people will look at these practices and then say, yes, they were fair in the way they did triage. They did not prioritize someone who was more richer. They did not prioritize someone who was politically connected. They used the same yardstick, right? So that would perhaps lead to more trust. Of course, it's not easy in our setting, but those are the kind of things which become more important during pandemics. For those of you who are from the forces, you will know that triage guidelines also operate during war or conflict, right? You have to sometimes take tough decisions around who to provide care to and who to perhaps just help with pain or palliation, but not do aggressive care, because you have to make choices in those kinds of frontline settings. Veracity, which is telling the truth and being transparent about what the data is saying, right? And making sure that the data is available to external stakeholders. That applies at multiple levels. For example, are we being upfront about the number of infections? Are we being upfront about the number of deaths which have happened? Are we being upfront about the number of beds which are currently available, oxygen availability, or are we not doing that? And that is causing a lot of misconceptions, etc. And within these settings, again, how do you exercise the principle of respect for persons in a way that it can be truly representative of how it is? Now, one of the challenges which, of course, happens for providers and for administrators is what kind of demands can we put on our providers, right? Because early in the pandemic, as you know, there was not a lot known around what is happening, how serious is this, what could this mean for my health? And a lot of providers were understandably anxious about it, right? So as Albert Camus said in The Plague, they did not know what was awaiting them. They did not know what will happen, when will it end. And at that point of time, their priority might have been a duty to care. So even in the absence, sometimes, for example, of PPE being available, even in the absence of a clarity around the infectious nature and the potential mortality or the risk of mortality, many health professionals stepped forward and provided care. So this is their due, because they belong to a profession where duty to care is considered a primary responsibility, right? A strong duty to care. But is that fair to only expect them to provide care and not receive something in return? And that is what is typically known as reciprocal obligations or reciprocity, right? So some of the areas which have been identified, for example, which institutions, health systems should ensure is there insurance and coverage in case something goes wrong? Is there personal protective equipment, training, and clinical supervision which is being offered, so that when individuals are dealing with a new kind of health threat, that they are supported to the extent possible? Are their working hours sustainable? Are they being provided adequate rest? Is priority testing being given to those providers who might start to show symptoms? Because of course they might have acquired infection during the course of their work. So should they be receiving priority testing and priority best available medical care if they get sick? If they get sick, will that be covered from a financial perspective? Would there be the possibility of looking at wider social factors like childcare? If both providers are busy doing extra hours, then who takes care of their families? They might have older parents who are also having comorbidities. They might have young kids. Are there possibilities of providing some kind of social protection so that they're able to focus on providing care to their patients? How is their contribution acknowledged? Mental health is a major issue, which we're still dealing with some of the consequences of the pandemic experience, and this has not been really explored adequately. What was the kind of impact on mental health and well-being during the pandemic, specifically on providers? And this is where I think there's been a lot of guidance coming in also around how administrators and practitioners can be looking at issues such as resource allocation, priority setting. For example, principles for fair allocation. If you have limited resources, limited services, limited interventions, limited drugs, limited vaccines, then what kind of principles could you use for ensuring that there is fair allocation? So issues around transparency, ensuring that those who are potentially impacted, individuals, communities, countries, have some way of engaging with the priority setting exercise. Doing this in a consistent manner so that no one can say that this exercise was taken over by a third-party interest which was conflicted. Taking accountability for ensuring that this is done, right? And in terms of making decisions around who to prioritize, let's say if there is only one bed remaining in the ICU, or you only have a few vials of a medication which is known now in evidence to be useful, then how do you decide? Should it be based on an equality principle, which means that everyone is considered equal? Should it be looked upon from a more medical best outcomes approach, which means that whoever is likely going to benefit the most clinically, maybe someone who's younger, maybe someone who's healthier otherwise, as compared to someone with comorbidity, should they be the ones who should be prioritized? Should you be prioritizing the worst off, those who are perhaps the most sick, the ones with the most comorbidities, the oldest? Or should you be prioritizing those who are tasked with helping others, like doctors, nurses, paramedical staff? That if there is only one bed available, then the provider is the one. If they are patient, also a patient, that they should be the ones getting it, right? So all of these are choices, and some of these, of course, have moral implications. But will frameworks help you make a decision, right? And this is where those kinds of frameworks become, or guidelines stuff become useful. Now, another area is, can you make it mandatory for employees, staffers to have to take vaccines, right? And this was also, again, a hot topic, that should we be stopping providers from coming to a hospital if they have not taken 1 dose, 2 dose, booster dose? And when can we make an intervention mandatory? Right now, as you would recognize, that a lot of evidence was continuously emerging, but a lot of these vaccines were also authorized or allowed to be used under emergency use mechanisms, right? Which means that all of the evidence is not yet available, but you're taking an interim step based on some early level data that you have in the interest of public health. But in that scenario, can you make it mandatory, for example, for COVID-19 vaccination to be taken, for you to allow them, for your providers or for your patients to come and access care, right? And this is where I think, again, there's been a lot of discussion in national and international fora. And one of the ethics guidance from WHO speaks to the fact that this needs to be proportional to the risk of the disease that we are dealing with, the necessity to take such a step, There should be sufficient evidence that the vaccine is safe. There should be sufficient evidence around vaccine efficacy and effectiveness. There should be sufficient supply of the vaccine, because if you tell individuals that I'm going to allow you to work only if you take both the doses, but those doses are not available, then how is that person going to be able to satisfy that requirement? There should be public trust around implementing any kind of measure like this. And usually this should be also not implemented on a regular basis, only in special circumstances. And there should be some kind of an ethical process of decision making before anything is made mandatory, right? So those were some of the ethical principles which were offered to help make these kinds of decisions. And this is where I think the role of hospital administrators, such as all of you becomes important. How do we create spaces where we can use these guidance frameworks? How do we anticipate some of the challenges which emerge during health emergencies, but also routine practice? For example, organ donation, right? We know that organs are a scarce resource. So how do we deal with organ donation, organ transplantation in a way that can be fair, transparent, and equitable, right? So that, again, the appearance that certain individuals who might be having access to funds are the ones who are able to game the system, that leads to a lot of breakdown of trust. So, should it be based on need? Should there be a wait list which should be there? Should this be supported by the government in a manner so that anyone who needs it is able to access it, but not just those who might be financially well off? There are a lot of new age technologies which, as Dr. Bari was talking about, genomics, data sciences, artificial intelligence, machine learning as being applied to healthcare. There is usage of drones being talked about. There is a lot of data which is being generated, stored, and shared. All of these newer technologies and sort of the interplay of data requires us to be prepared as a system to deal with the kind of ethics challenges which will arise, whether these be around security, whether these be around privacy, whether these be around confidentiality, whether these be around ownership, whether these be around who has access to this information. If you are entering into an MOU with a national entity, a commercial entity, a foreign entity, then how do you ensure that this is still going to protect your stakeholders, your patients, your institutions? A lot of practitioners now are posting a lot of information about patients, cases, experiences on social media. What kind of guidance do you need to have in your own institutions to ensure that they follow ethics tenets when they do that patient privacy and confidentiality is maintained? There is minimal risk of harm to the patient, to the provider, to the institution by this kind of sharing. And in many ways, I see that AHA can play a leadership role, because many of these areas are still areas of gray. In fact, on Twitter, just over the last couple of weeks, I've seen some interesting debates around. There are so many practitioners now sharing images, patient descriptors, interesting cases in inverted commas. Should there be some ethics thinking before individuals do that? What kind of guidance do we need? And maybe here the role of hospital associations can be really important. Just this month, digital health standards, draft ones, have also been released by NABH. Some of you might have seen these. Again, because as the ecosystem is becoming more digital in nature, with Ayushman Bharat, ABDHM, etc., you will start to see that, again, it also brings it a lot of ethical issues with these discussions which are happening. An important facet, I think, as we were talking about also earlier in the pandemic realm, is how do we ensure that our providers, our staffers are also protected, right? And what kind of occupational health and safety programs do we need to institute in our own hospitals, etc.? And how do we ensure that, given that many of our institutions are short-staffed, many of our health workers sometimes are going through a lot of stress, that we are addressing the possibility of burnout and trying to prevent it, right, by taking care of our health workers. And this is an article which was written by the then Surgeon General, of the US, Vivek Murthy, who spoke about this being a priority in the US, but it's likely an equally or perhaps an even more acute priority in our country. Now, one of the areas which is important here to talk about or touch upon is the fact that because healthcare is so hierarchical, there are issues around how sometimes junior colleagues might be exploited, coerced, disrespected. And bullying is a reality. It's a reality in many institutions. It's a reality across cadres of health workers, but within cadres of health workers as well. And this is something I think administrators need to recognize. This is being increasingly recognized in research, in funding. The Wellcome Trust, for example, pulled away funding from a multi-million pound funding from a cancer geneticist in the UK because she was found to be bullying her lab juniors. And we know that papers have been retracted in major journals where similar issues have been there. WHO has had to fire one of their directors of one of the regional offices, the Western Pacific office, because he was found to be having indulged in racist misconduct, right? So even organizations like WHO are dealing with it, with this issue. So how are we anticipating some of these possibilities? What kind of systems do we have in place to ensure that it's not just about having a posh committee, but also we are looking at potential coercion which is happening, bullying which is happening. Now, healthcare, in summary, has evolved, right? This is an interesting photograph from probably 4 or 5, 6 decades ago, where cigarettes were available for sale in hospitals, and they were brought in by nursing staff to patients at their bedside. Of course, that would not be acceptable in today's world. Most of our hospitals now are smoke-free zones, but there's a lot which has changed in medicine in many ways, in healthcare in many ways. So what do we learn from that? How do we identify areas of gray and how do we try to respond to them? Aggressive care versus comfort care versus transition care, right? This is an article which was written earlier this year in JAMA by a third-year medical student, and she writes about having to take a decision about her own infant son, an infant son who had complex medical issues and was sick enough that they were anticipating that this child would die. So she had two choices with her family. One was to stay in the hospital and keep pursuing aggressive care, or take the decision to take her child home so that the child could die in her own bed, surrounded by her toys and etc. And she took that choice, right? And because she wanted a more tranquil, private, dignified death. Are we able to offer these kinds of choices in our institutions? Because the practice of healthcare and medicine, the way we are trained, is usually with this assumption that we should do everything within our power medically to try to save our patients. But end-of-life care, palliative care, transition care is something that we need to increasingly explore, right? Imagine in your own personal life, what would you prefer? Would you prefer for a loved one or yourself, if you are in that stage, to be hooked up to machines, to be in an ICU setting, ventilated, or would you like to be home, etc., kind of a thing, right? So these are the kind of things we need to perhaps think about. The other thing is, what is our kind of responsibilities? Almost 15, 16 years ago, when I was in in Canada doing my master's, the Indian Ocean tsunami happened, and I was only sort of tracking the developments remotely, but I was really troubled by the fact that there were journalists going into hospitals, taking photos of dead bodies which had been kept in the morgues, which were overflowing. And so, as health professionals and administrators, what kind of ethics do we need to take account of when we see these kinds of scenarios emerging? In COVID, when there were again similar situations where a lot of patients were dying within hospital complexes, do we need to owe it to our patients, their families, to offer them dignity in death? where there is no voyeurism happening of death of the kind sometimes that we saw during the pandemic as well. And how do we also, this is a new report which has come out from the WHO, how do we also get patients to be involved in these larger discussion around ethics, right? So persons with lived experience now are increasingly seen as a form of expertise. But do we engage with patients? What's our patient and public involvement and engagement plan? How do we do it in a way? Do we have a patient advisory board that we can have? And a few years ago, I had written this article in the Times of India. Around that time, I had been operated because I had a leg injury, and being on the other side, a patient, and seeing what it means to be a patient, made me reflect a lot. And I co-wrote this article with Nandita. Nandita is a journalist, but she also had MDR TB. So and she got deafness from one of the injectable drugs which are used for MDR TB treatment. And so this talks about the fact that patients need to be actively involved in decisions as well, and we should not talk down to them. So, how do we build mechanisms towards that is something for us to think about. I really like this article which was written in the BMJ in 2021 by Matt Morgan, and he talks about the fact that the way healthcare operates makes certain assumptions. If you take a very managerial approach to healthcare, then you look at it as printing money, beds being bought. But healthcare is more than just the bed, the CT machine, the MRI machine, the IV equipment, the fancy robotic surgical apparatus. Every intensive care bed needs a whole village of people: nurses, doctors, pharmacists, paramedical staff, managers, administrators, to run and make that intensive care bed functional, right? This bed needs water, power, heating, lighting, scanners, drugs, food, toilets for it to actually be able to provide care to a patient. If we only needed a bed, we could just go to the local carpenter and get a bed, or to the local IKEA store. But it needs much more than that, right? And that is what we need to think about, that what kind of an environment, what kind of an ecosystem, what kind of a framework can we build so that our hospitals become areas, environments where we are able to deal with issues in a more proactive, transparent manner, and where our staff is supported so that when they face moral challenges in healthcare, they're able to perhaps better respond to them. So I know I'm a bit over time in terms of what was allotted to me, but hopefully I have left some areas for reflection and discussion. Thank you for the opportunity, and apologies for that small break I had to take during the presentation. So I'll stop sharing now, and back to you, Dr. Bari.
Thank you so much, Dr. Bhan, for that exhaustive and thought-provoking presentation into the world of ethics that we all face. And medical ethics definitely is an important aspect of overall patient care that we provide. Now, I would request the audience, if they have any question for the speaker, they may please go ahead. I don't think there's any question as of now.
Bari, if no one is asking, I have a question for Anant. Anant, you mentioned about the violence against healthcare workers. There is also ethical dilemma many times when the patient is aggressive, not necessarily violent, or maybe abusive. In those conditions, doctors' responsibilities to those patients and the doctor's right to refuse the treatment or care to that patient, and what roles the hospital administrators play in such situations. Any thoughts on that?
Sure. So I think, as I alluded to, I mean, I certainly come from a perspective where any kind of violence on a healthcare provider is not accepted, right? I mean, I think that is beyond any doubt. But we also need to understand that sometimes these kinds of acts happen in an environment where there has been a trust breakdown, where sometimes it is based on a certain conditioning, in mental health and in pediatrics, as I've discussed with many colleagues, there is a recognition that many individuals have been failed by the system, not just the health system, but by the social system as well. And so they fundamentally have a lot of mistrust against everyone, right? Because they have not just been given any kind of protection by the state and positions of authority. So they might come across as being distrustful, aggressive, as you were saying. And so that kind of nuance, do we have mechanisms to capture that? How do we deal with that in a more sensitive manner, especially in settings which are so overcrowded already, right? It's not like in a public hospital where you have a 200, 300 OPD, then how do you create that space for that engagement? Can we have specialist trained staff, counselors, psychologists, social workers who can help out? Do we have mechanisms where safety is ensured, but we also try to understand what is happening, try to learn from that, and try to anticipate that better? So I would start from a premise that no kind of violence is acceptable, but I would also not consider it the case that the response is purely about having more security guards and having police acts, right, or criminal acts, without understanding what might be the reasons why there might be aggravated cases sometimes happening. So there is something within our control to be able to address some of these issues, but of course, also clearly not allowing for any violence to happen from the patient side, but also within the healthcare realm, right? Remember my point around bullying. There is a lot of violence which happens within the health system as well, within the hospital system as well. And that kind of violence we don't speak to adequately as well. This is because of the hierarchy which also operates. And that is also a kind of violence that we need to talk about, emotional, sometimes physical as well, right? And how are we dealing with that is an important point to discuss. But thank you for the question.
Yeah, Anant, thank you, Anant. Thank you. And thank you also for this wonderful presentation. And Dr. Bari, I think Dr. Rajiv Patni has
Dr.
raised his
Rajiv
hand.
has probably a question. Dr. Rajiv, please go ahead.
Thank you, Dr. Bhan. Excellent presentation, and I think it should be a compulsory exposition for all administrators. I would like to, to move into an area which you did touch upon, and that was of digital health. And an emerging area in digital health is that of artificial intelligence, which brings up very important questions of agency, autonomy, accountability, etc. And whenever technology is involved, accountability takes many perspectives. Accountability of the people who have developed the technology, and accountability of those who are implementing the technology. I'd like to very much to hear your views on artificial intelligence. Right.
Sure. Thank you, Dr. Rajiv. That's a great question. In fact, this is something that many of us, I wouldn't say are on top of it, because one of the challenges with healthcare generally and the field of medicine is our textbooks, our knowledge usually drags behind scientific advances. So, not all of us can always be on top of everything which is happening. And the field of new data sciences, AI, ML is growing at such a rapid phase. ChatGPT is a good example, right? That's another area where you've seen just in literally a couple of months, you have a fourth version, a fifth version, and the kind of interesting use scenarios that we are seeing even in healthcare of that being operated. Not very few of us perhaps really understand what that could mean in terms of our practice and the way we run our hospitals. But what you said is exactly right. At the end of it, we need to talk about the fact that these are largely tools, right? These are tools which you utilize, you implement, and you could do that right, or you could do that in a way that it is a gray zone. But you need to have mechanisms, hence, to ensure that any deployment is done in a very careful, thought-through manner, where there is a clear set of guidance, there is an understanding of what you're using the technology for, what is the evidence base behind it, how do you ensure fidelity and veracity, where is this tool is best used for, but also how do you build in checks. So we are just starting one of the largest studies in mental health, around 1,500 patients, where we will be using AI ML for precision treatment in primary care for depression. And while that study will start later this year, we will be doing the pilot. A lot of our discussion already over the last few months has focused on developing the protocols, the standard operating procedures, our own training to be able to know how to deal with this, right, and how to prepare for it. And also, we have to recognize that sometimes there is a reliance on third party, which might be commercial. Sometimes there's a reliance on foreign institutions where they have multi-billion-dollar funding, so they've set up large research institutes. So for our own, from our own perspective as institutions which are doing this kind of research, we also need to ensure that, we are not becoming third-party vendors to create knowledge for someone else, right? But we are actually actively engaging because it's our own patient data, it is our institutional data. So a lot of that will require careful thinking, and I think the leadership of institutions and associations like AHA can be really instrumental there. So new age technology is huge gray areas, a lot of important area to work in. Thank you.
Thank you.
Thank you, Dr. Bhan. Thank you, Dr. Rajiv, for the question. Just before we wind up, Dr. Anant, I have a question regarding, you spoke of something about building mechanism to give choice to the patients. What do you recommend can be these mechanism which will actually empower the patient to be part of his treatment or how he becomes part of his own treatment? Because majority of our hospitals, majority of our doctors don't give much choice to the patient. So what could be these mechanisms that we as administrators should include in our systems?
Sure. So I think it's probably not the case that doctors or providers don't want to involve patients in decisions. It's just the way that we are trained. We are trained at looking at patients as cases, a set of symptoms and signs from a diagnostic perspective, and then taking a decision, right? If we change the culture to be one where we consider the patient an important stakeholder in that process of providing treatment or healthcare, then it might actually change the paradigm a little bit. There's been some really interesting work, including in India now, on earlier what was known as supported decision making, now called shared decision making, where you work with patients and patient allies in being able to look at those issues. And this is, I think, also extremely important, especially in conditions which might be more chronic in nature, right? Because one of the challenges in areas such as TB, mental health, is that you can initiate people on treatment, even non-communicable disease, but then they don't stay on treatment. They stop taking medication, and then of course that leads to complications, etc. Or they don't come back for your regular checkup. So how do you actually work with them so that it becomes a little bit more of a team effort, and you create an environment where they feel also responsible and involved? It's not easy, but I think there are certainly mechanisms where certainly using more softer skills, by doing more humanities-based approaches, by working with your staff on some of these trainings which can be instituted, that can be tried out. And we've seen that happen with disability spaces. We've seen that happen with marginalized communities. So some of that kind of exposure to our staff might let them at least look at it slightly differently. As I said earlier, for me, the biggest realization was becoming a patient myself. When I was on the table getting consent right before surgery, someone asking me to sign the consent form, here is where you sign, without any description of the consent form, where I was being woken up every 3 hours because someone had to put in a BP and a temperature and a pulse measurement, when I was just trying to get some sleep and rest because I was in pain, but someone had to follow the protocols. Those are the kind of places where you realize that, this is what patients undergo. And if I knew earlier, maybe I would have thought about doing things differently. So I wouldn't want any of you to become patients to realize that, but just to make the point that I think, it helps to hear the patient narratives and reflect on them to be able to know where things could be done better.
Thank you, Dr. Bhan. Thank you so much for your insightful talk, and all the participants who attended today in the webinar. I think we can call it a day. If there's no other questions, I don't see any other hands. Thank you, Dr. Bhan. Thank you so much. And thank you all for attending the webinar.
Thank you. Thank you for the opportunity.
And
Pleasure.
thank you, Dr. Bari, for moderating. Thank you.
Thanks a lot. Take care, everyone.